Thanks very much. Good morning, everybody. I hope you've had a chance to take a quick break and digest some of the really interesting information we heard in the first session. I'd like to share with you some thoughts on sociocultural issues that we've grappled with in our work in breast and cervical cancer in low and middle income countries. So I'll start by actually trying to give you a sense of what we're talking about with socioculture. We've heard references already in the first session to some of these issues, but not named them as such. Then I'd like to talk about why they're important for cancer control programs, and I'll use examples from our work in breast and cervical cancer and suggest some lessons that have been learned and some possible recommendations that we could consider. So when we're talking about cultural factors, we're talking about beliefs, customs, practices, and behaviors that are shared by any group. Social factors, we tend more to be thinking about education, income and occupation, ethnicity, race, religion, political affiliation, and geography. We know that health issues reflect a complex interaction between biological factors and the health system, and then these individual factors, many of which are governed by socio and cultural kinds of issues. Sociocultural factors are important both as determinants of health, but also as influencers of how health interventions are perceived, how they're taken up, and how effective they may be. And I'm actually going to focus more on the second role of their role as influencers rather than the ideologic role, which is a whole other topic for us to get into. It's helpful to have a framework for thinking about these issues, and the ecological model is one that has been helpful for us that seems to fit well with some of the issues we're talking about. And of course, ecology, we're talking about relationship of organisms and their environments. And in health, that plays out in a way that thinks about health behavior on these multiple levels. So starting at the individual level, the relationships that the individual has with close interpersonal relationships, particularly family, with their place in a larger community and how that may impact on issues. Also with key institutions, in this case often health institutions, but in the case of HPV vaccine, it was also with educational institutions. And also then how that fits within a larger policy environment. So this is one approach. There are other ways of thinking about these issues, but this is one that we have found to be helpful. Salas et al. Have talked about 4 core principles in thinking about ecological models, and these include the fact that these multiple influences on health behaviors occur at all these different levels. And there actually is even interaction across the different levels, but they are very behavior specific. So one model that will work for one area of health may be quite different, in the relative influence and importance of these different levels may vary. So we do have to think about them in a behavior specific way. And as we're designing interventions, we need to think about all these levels together, and we are most likely to have effect if we do that. So when we first started thinking about how to introduce HPV vaccine into settings where there had been no immunizations beyond the child program and some for tetanus immunizations for adult women or pregnant women in particular, we were struggling to think about how to gather the relevant information to shape the approaches we were going to take. So we needed a framework for gathering data to develop program strategies, how we were going to introduce the vaccines, educational materials, how to reach people, raise awareness. And for us, we found that this ecological model was very helpful in guiding what we were doing. It enabled us to really consider factors about individual girls and what they would think about vaccine and about cervical cancer if they knew anything about it at all. Key interpersonal influencers, particularly their families, but also close people that they worked with directly, their teachers. Community influencers who might create an environment, so influential religious leaders and other community leaders. Institutional actors like health workers. We heard how important at the end of the last session, how important health workers are in influencing people's perceptions, and then the larger policy environment. So this guided all the questions we asked. We were fortunate in being able to do about a year of qualitative research around these issues before we launched the program. So why is all of this important for cancer control in particular? I mean, we want all healthcare services to be efficient and effective and acceptable and available on an equitable basis, but it's actually particularly relevant to cancer control, I think, prevention and control. And these are just a few of the reasons, I think, why this is so important. Stigma is a particular issue around cancer, partly because it's considered to be so fatal, which leads to high level of fear about it. Lack of understanding of the disease process. We use one word, cancer, for some very different diseases. And people who have limited access to information about biomedical processes find cancer quite mysterious, which always heightens the sense of fear and uncertainty. And what has always attached, because we don't understand it, is this fear of contagion. So all of these factors together lead to a high level of stigma, which may be different in different societies, but we know a lot of it is there. Another aspect, I think, that makes it difficult to deal with cancer, and it is related to a cultural sense that many cultures are not future-oriented. They're dealing with the present. And the long time lag that occurs for cancer to develop and for it to become fatal makes cancer prevention in particular very difficult to do. You're telling people do something now, like give your 12-year-old vaccine for something that you've never seen occur before 50 years old or 40 years old. And if you don't work, if your immediate need is food on the table, then it's difficult to say, do these preventive measures that will pay off in 20 or 30 or 40 years. Also, the high expense is a huge barrier. This is an economic barrier that leads to very inequitable access, as we've seen, both within the US, but certainly in the global scene, and frequently pushes families into poverty or deeper into poverty. So these economic issues are societal issues that are quite important for cancer in particular. So I'd like to draw on some examples from our work at PATH on breast and cervical cancer over the past 25 years. Many people still don't realize that cancer is an important women's health issue in developing countries. And we heard some references to it in Dr. Boyke's talk this morning. But we see here, these are figures from 2012, the number of deaths from breast and cervical cancer combined far outstrip maternal mortality, which has been a major focus, an important focus, and finally has gotten the investment that is needed to get started. And we're seeing some benefits from that. And maternal mortality is coming down. But very few people realize that breast and cervical cancer far outstrips this in low and middle income countries. And the differences between rich and poor, between developed and developing countries is growing. We see here on the left estimated breast cancer deaths. The red bars are from the more developed countries. This comes from GlobalCan data. The blue bars are from lower and middle income countries. And we see the progression from 1990 to 2010 and the projections for 2030. And you see that the difference between them in breast cancer, we're seeing a slight increase in the developed world, and that's partly with the changes that are continuing to happen in increases in mortality, but a huge increase in the less developed countries, in the blue bars. And on cervical cancer, the graph on the right, we see that's even more striking, where the red bars are going down, leveling and going down as cervical cancer deaths continue to decline, thank heavens, in high-income countries. But the number that are expected to increase in cervical cancer in less developed countries are really very concerning. So there are opportunities that exist, and where do we put our primary attention? In breast cancer, for example, we are putting our primary attention on early detection, whether that's through screening, active screening, or simply improving symptom awareness so that we get earlier detection. And we are needing to make sure to link that to effective treatment and also psychosocial support for recovery after treatment. This is a set of diagrams that were developed for our program in Peru, simple diagrams that were developed to improve symptom awareness. These are used in educational talks by community health promoters in Peru. In cervical cancer, our primary efforts are on prevention. Primary prevention by HPV vaccine and screening and treatment for precancer. We can make a huge difference there. So what kinds of sociocultural factors are important for breast and cervical cancer? These particular cancers are tied to sexuality in ways that many other cancers are not. And beliefs about the body related to sexuality can greatly affect women's willingness to seek treatment for symptoms associated with the breast or the genitals. And that can delay both early detection and decisions about treatment like surgery. Beliefs about disease causality being related to sexual behavior can raise concerns about being stigmatized if you're diagnosed. I know in Ghana, Ben Anderson and I were there 8 years ago, I think, and people would tell us that there were beliefs and myths that women got breast cancer if they were, in their sexual practices, men fondled their breasts too much. And there are strong beliefs in many places that cervical cancer is due to promiscuity. And we almost contribute to that in our scientific presentations because we talk about multiple partners. And yet I saw a study just recently that said multiple partners were linked, and it was partners more than 3 in a lifetime. So, but it only said multiple partners. It didn't say more than 3 in a lifetime. So I think we have to watch for how these factors are affected ourselves when we do it in our own work. And concerns about loss of sexual function or desirability, especially loss of the breast, can also drive treatment decisions in a way that make women delay or even forego life-saving treatment. We've seen this even in the HPV vaccine world, where there have been concerns that the vaccine would encourage more risk-taking by young adolescents. Now, fortunately, there have been lots of studies in the last 7 or 8 years to show that that is not at all true. Sometimes even the reverse. The education around the vaccine may encourage more careful behavior, but it certainly has come up, and it's because it's related to sexuality. And also, simple modesty concerns can be very important in preventing women from getting care, particularly having speculum exams if there are only male providers available. In Kenya, for example, when we had a program there some years ago, we trained nurses to do visual inspection. Well, probably a third of the nurses are men. And in communities, it just was not acceptable, especially in small communities where you knew the man, and he knew you and your family. And so this can be a huge limiting factor. So there are other cultural issues that we know are important. Fatalism is a really important one. We know that that creates a passivity sometimes, an acceptance that can greatly affect how people react to services. And it varies from place to place, and the underlying cause of it could be religious, it could be cultural, it could be related to social status, the sense that you're at a status that you have no power over your life, and therefore you take whatever is given to you. But it's obviously a serious concern, because in health it becomes operationalized as being either negative, that you don't want to do anything, or just a passive sense that you don't need to take an active role in your own care and protection. And in breast and cervical cancer, we certainly see that play out in willingness to seek care, and it's especially difficult to counteract if you don't have visible survivors, because that sense of fatalism is reinforced by the sense that people disappear. You don't see anybody survive cancer. And so that's where, as we've said this morning, the role of survivors is very important. Another important cultural value can be fertility. That's a huge concern in many societies. Fertility is often the determinant of women's status in society. And while this may not affect breast and cervical cancer as much, where women are often beyond the childbearing age, it certainly has been important as an issue in Africa, for example, for parents who are worried about any fertility risks to girls getting HPV vaccine. Now, of course, there are no risks, but it highlighted for us when we discovered this as a concern, because it wasn't one of the ones we were anticipating, it highlighted the importance of addressing that concern in any educational materials we give out about the vaccine, that that's a legitimate question people have, and we have to address it actively and reassure parents that there's no fertility risk. When we think about some of these other social issues, age, gender, social position, all of them combine in a sort of perfect storm to really disadvantage women in their mid-adult years. In many societies at that age, women have very low power to act on their own behalf. They may need permission to go to services. They have less access to resources. And the things that are needed to enable them to get care are at great risk because of these social factors. Social customs also often set up the dictate the fact that women feel that it's other people's well-being, their partners, their husbands, and particularly their children, whose needs have to come before their own. So if there are allocation questions and priorities to set, women put themselves last. And again, that delays or prevents them from getting treatment they need. So when we started thinking about HPV vaccine, an important first step in planning any intervention for us was to do formative research, qualitative research, to help us understand more about the context, the ecology, as we say, of the group for whom the intervention is designed. And in that kind of qualitative research, you can identify potential factors and concerns that the population will have, and can develop a conceptual framework like the ecological model to guide the questions that you ask and how you gather that information. But we think that it's also critical to start out by searching the literature. There's really a wealth of literature available already that can be helpful as we try and design interventions that will work in these diverse cultures that we're talking about. And of course, the importance of a multidisciplinary team. We heard that referred to this morning as well. I know on our team we had an anthropologist, epidemiologist, sociologist, an economist, and clinicians. And I'm sure that in different settings there may be other specialists that you would want to include in your team. Sometimes it's easier to change the technology than it is to change the culture. Culture is really strongly seated. And sometimes you have to recognize that there may be another way to go about this to do what you're trying to achieve. For us, we work on HPV testing, and one of the advantages of the CARE HPV test that has been developed for low resource settings is that it's been validated for use with self-collected vaginal specimens. And this graph here is a educational material that was developed in Guatemala, where they're introducing HPV testing now to be done with self-collected specimens out in communities. And this can overcome some of the modesty concerns that women have. Women who don't want to be examined by somebody can take the sample themselves and just hand it over to a health worker who can then return it to the lab for testing. It may raise some other modesty concerns for women who are not used to ever touching their genitals. But we've been really surprised. That was a concern that was raised in a lot of countries, and we've worked now in 6 or 7 countries using self-collected specimens. And it's interesting because when we go in, usually the doctors at the top level say, oh, our women would never accept this because they would never be comfortable with this. And then you go the next day and talk to the community, and the women just says, yep, this sounds like a great idea to me. And when we've taken it out, we find 85 to 90% of women accept it. And the ones who don't, it's not so much about modesty, it's they're afraid they won't do it right, or they're afraid it might hurt. And so we've had to adjust because we talk about, oh, you use a little brush and you insert it in a brush, and their image is like a toothbrush or something. So you have to show them and let them have a sample brush that they can feel how soft it is and that kind of thing. So these are some of the issues that you have to think about as you're moving forward with these kind of things. But it does really reduce some of the barriers. This opportunity of self-collection can reduce some of the barriers. We know cancer survivors play a critical role. Reach to Recovery has a long history of doing that, reaching out to support groups and creating advocacy campaigns and showing that people can survive and reducing the stigma. We've also worked with patient navigators in Peru, helping women with breast cancer go through a pretty fragmented healthcare system and make sure that they get diagnosis and treatment. And it's important to include sociocultural variables in your information systems so that you can track them and monitor them and know whether you're reaching these low underserved groups, which is especially difficult to compete for space on the health information system. So it is a challenge. So sociocultural factors play a critical role in determining how people react to health messages and health services. Both informal and systematic qualitative research on these factors can really help us understand them before we get started, and when you run into problems, to understand the source of the problems. The role and magnitude of impact of these factors is specific to particular topics and geographies, so we have to learn from others, but also come back into the specificities of where we are. And if we have careful attention to these factors, we can move closer to achieving effective and equitable programs to control cancer. Thank you.